to start that. Our first presentation is by Miguel Blancarte, The Importance of Community and Community Building for Health Equity, a united approach to addressing Latino and Black disparities before COVID-19.
Hi, good afternoon, everyone. My name is Miguel Blancarte Jr., and I'm really happy and excited to be here with you all. Hopefully everyone's having a great afternoon. If you're in Chicago, it's sunny and it is warm out there. But I want to go ahead and start with this presentation. Let's try to share my screen now. Give me 1 second. Alrighty. All right, can you folks thumbs up if you can see my screen there? All right. Sounds good. Well, as I mentioned, thank you very much for having me at the Health Equity and Social Justice Conference. My presentation today, the importance of community and community building for health equity, a united approach to addressing Latino and Black disparities before COVID-19. Again, my name is Miguel Blancarte Jr., and I do community engagement, health equity, and partnerships with and for CORE, Community Organized Relief Effort. And with CORE, we're doing the Chicago COVID-19 response, which I'll get into in a little bit more. But first, I wanted to start off by just mentioning a couple things about CORE. CORE, Community Organized Relief Effort itself, is a nonprofit organization, a 501c3 that was established as a result to the 2010 Haiti earthquake due to the devastation and the inaction really of governments to provide aid. A couple of individuals decided to set up this organization, and our mission is to save lives and strengthen communities impacted by or vulnerable to crisis. One of the focal things about CORE is that it's really unwilling to ignore inequality. And so it is focused on being reactive and proactive to providing relief and to addressing inequity. So I just want to mention a little bit more about what CORE is doing here in Chicago. As you folks might have remembered, the city of Chicago announced on May 11th that they were going to go ahead and bring about COVID-19 testing. When this pandemic started, there really was a lack of coordinated federal response and plan to address this pandemic. When it came to testing, if you all remember, back in March, April, even May, when it really, when testing was somewhat rolled out, it was very difficult to get tested for COVID-19. The first test that the federal government developed, there ended up being some issues with that. The CDC announced that there were some issues to begin with that first test. And unfortunately, that really exacerbated the problem. In addition to having very limited testing, I remember I myself tried getting tested here in Chicago through one of the IDPH sites, Illinois Department of Public Health sites. Unfortunately, because it was very limited at the time, where even if you wanted to get tested, it was just, there was such a stringent requirement to be able to get tested that it really made it somewhat obsolete. Wherefore, in May, the mayor, and I really applaud the mayor of the city of Chicago for announcing this and for really taking a lead to this. Again, just because, as I mentioned, because there was really no coordinated response from the federal government, it really did come down to governors and municipal leaders to really be able to provide and address this relief. So the mayor did announce that the Chicago Department of Public Health was going to start COVID-19 testing. With that, the city of Chicago and CDPH went ahead and brought in CORE. Again, CORE, we provide relief where pandemic is and where need be. CORE was doing testing in other cities, started off in Los Angeles, LA. CORE is actually headquartered in LA, but started off in LA. We're now doing testing in various cities, including Atlanta, New Orleans, for example. And so with announcing this testing, the city of Chicago partnered with CORE to be able to provide the testing itself. So some of our leaders for CORE came into Chicago, assessed the situation, and we decided, that yes, this is something that we were going to do, and we started providing COVID-19 testing via static sites throughout the city of Chicago. This was extremely important, not only for the city, but really to address racial inequity. The city of Chicago, along with the Department of the Department of Public Health, strategically decided to locate these static sites in areas that were most impacted by COVID-19. As a response through the RERRT group, Racial Equity Rapid Response Team, there was the strategic effort to really focus in on communities being most impacted. And again, those communities most impacted were Black and Brown communities. Again, at the time in May, there was still somewhat data kind of coming in about who was being impacted the most and how it was affecting not only positivity rates, but really morbidity rates as well, because there was such limited testing at the time being done that it was certain facts and certain information was known. However, the extent of it really was not known because the sites that were providing the testing at the time when testing first came out in March and April, and even at the beginning of May, the data, because it was so limited as to who can get testing, because it was such a stringent barrier and threshold to getting tested, a lot of folks in our Black and Brown communities were not necessarily being tested. However, even so, with the data that was coming out of that, it was showing that Black and Brown communities were the ones most impacted by COVID. In June, after a little bit after a month of having our static sites operating, we started with our first static site at Maria Salcedo Elementary Academy in the South Lawndale community in Little Village. And I was actually directing that site up until this new leadership role that I have now with CORE as of about 2 months ago. But in June, a month after we started testing, the city also announced we were advocating, CORE was advocating for mobile units to be able to establish a strategic mobile setup in order to really be able to upend these resources directly into communities. Yes, our static sites were already very much in communities that were impacted. However, the mobile units would be a way of being able to directly go into a particular neighborhood, a particular zip code, where either positivity rates were just extremely high, or there was just a need for additional testing. So it was announced that we were going to go forward with our pilot testing program. And again, this is something that CORE very much advocated for because we knew that this was essential. I am born and raised here in Chicago. I'm born and raised in this neighborhood, Little Village, where I reside now. And I know similar communities, our Black and our Brown communities, our neighborhoods that have consistently been left at the peripheries of policies, laws that are really um, that don't provide equity to the communities, communities that are underserved, under-resourced. And so knowing that already about certain communities, we knew that COVID was going to have this added impact. And so mobile testing was really going to be necessary to enhance the community-based testing for the city. Again, because we wanted to test as many folks as possible, but really folks in most impacted communities, because the unfortunate reality is that a lot of these folks are essential workers and don't necessarily have the ability to work from home. So they do kind of really need to expose themselves to this virus, being out in the streets, getting to be able to get to work and back. So that propensity of being more susceptible to COVID-19 really just made it clear that mobile testing was going to be necessary to enhance CBT, community-based testing. And so we did start off with the mobile testing units. We have every week we deploy, in addition to our static sites, we deploy 7 weekly mobile sites. And these are really guided by data that comes directly to us from CDPH. We obviously have a very robust and strong relationship and partnership with CDPH, Core does, because if you're going to be doing the testing, something like this, right, it is the city's testing administered by Core. And we rely on that data. So we have meetings with the CDPH epidemiologists to review the data and really determine where we need to deploy our mobile units. So, again, that's very strategic as well, being mindful of the extremely high positivity rates and where we need to deploy them. So every week, like I mentioned, we have 7 weekly mobile units that we deploy throughout the city, in addition to these static sites. And now these, when we deploy them, when my outreach team and I are looking into what venue in particular, what site particularly we're going to be going into or we want to go into, it is really important to partner up with organizations that are focal and key to that community, to that neighborhood that we're going into. And there are various reasons for that. First, right, we're looking for sites in order to be able to do the testing. We ask for, we've been doing outside testing, so whether it's a lot or a space that just allows for testing. And another thing I want to do note that this is also very important to bridging about the divides between and really helping to bring about equity is that we offer testing via both walk-up and drive-through as well. At our static sites, that is the case. At our mobile units, it might be one or the other or both, but that is extremely important in order to be able to address health equity in the communities that we're going into. But going back to how we partner up with the different community-based organizations, faith-based organizations, or just any other organization in going into these different communities, when I approach them is we want to bring in the testing because this is really important to for health equity in the neighborhood to address this pandemic and to really try to curtail and prevent the spread of the virus as much as possible. But we really want your help in ensuring that community members from that zip code, from that area, from that neighborhood do come out to get tested. Because if we really do want to stop the spread of the virus, we need to test folks and determine whether they are COVID positive. If they are COVID positive, for them to take the necessary steps in order to really help mitigate the spread of the virus itself. So we deploy our 7 weekly sites, and we offer both walk-up and drive-through testing. And the organizations that we partner up with, those are extremely important to me, because I know the importance of these organizations, be it community-based or faith-based organizations, because when it comes to bridging that divide, really, and being able to get direct messaging to community members, it is important that messaging comes from organizations that folks trust, right? Because that trust is extremely important. Unfortunately, because of the political rhetoric on a national scale, that has trickled down to municipal level mistrust or distrust, really. And so working with community-based organizations is extremely important. And so these are just some images from the city of Chicago when it comes to our mobile units, for example. For me, being born and raised in this city and knowing a lot of the disparities that are consistently and continually seen time after time again, mainly because of these social detriments of health, right, that we continue to see. I mean, everything from economic stability to education, social and community context, again, healthcare, access to healthcare, lack of healthcare resources. It was really important, and it is really important for me to ensure that we are going into our Black and our Brown communities. And while, I am not Black myself, while I am not African American, I do understand that the Black and the Brown communities share a lot of underlying similarities, right? I realize that we're not in the same boat, but really we're sailing in the same ocean, and we're sailing there together. So when it comes to addressing all of these large tides that are coming to us time after time again, it is extremely important to continue building about those relationships between the Black and the Brown communities throughout the city. And this is just some data as to morbidity and positivity rates in the Latino and Black communities, right? Where if you take a look at the number there, the Latino and the Black rates tend to be some of the highest ones. This is data that was released up until the end of July. But however, all of the data has consistently shown that Black and Brown communities are disproportionately impacted when it comes to infection rates. The Black community in Chicago is 2.3 times higher than that of whites, and the Latino rate is 3.4 times higher than whites. That is the infection rate. Mortality rate for the Black community, it is 2.8 times higher than whites, and for the Latino population, it is 1.7 times higher than the white community in our city. And so knowing how this is disproportionately impacting our communities, it is extremely essential and necessary for to build up that divide between our communities and work together to address the inequities. Just some more data on some of the zip codes that are high up with high positivity rates and deaths. And I'm sure we've all seen these, but if you also take a look again at deaths, when it comes to deaths right now, the Black population in the city, this was up until the mid-October, in the city of Chicago, over 1,200 deaths in the Black community, and within the Latino community, there were close to 1,000 deaths. We really need to be mindful and remember that, consistently remember that when addressing COVID-19. Another thing that I do want to say really quickly, and I'll go back to this image, is again that the Black and the brown communities, right? We have consistently seen a lot of disparities. And when we go out to our mobile testing units, for me, it was extremely critical, not only to address COVID-19 when it comes to testing itself. For me, for this position with CORE, again, I am not a city employee. I am not, don't work for the city nor CDPH, but we are in partnership with the Department of Public Health in order to respond to COVID-19. And so for me, it's not only about the mobile testing, but it's really about being able to provide additional resources to community members, to our Black and our brown folks, because we have seen the disparities, and we know that not only has this pandemic exacerbated a lot of individuals and families, but really to a large extent, this pandemic has broken a lot of individuals and families to the point where we need to continually provide additional resources. And so if there is something additional that I can partner up with an organization in order to bring, whether that is flu shots, whether that is distribution of back to school materials for students, whether that is food pantry distribution, whether that is resources to potential housing resources that are there for community members. That was something that we were doing in order to really address the inequities and bridge that divide between our Black and our brown communities, and help alleviate inequity. If anyone has if anyone has questions, I know there's going to be a Q&A section, but I'll leave my information there for you all as well.
Excellent. Thank you so much, Miguel. And we will have the Q&A session at the end for sure, but thank you for sharing your contact. Our next presenter is Marie Heffernan from Lurie Children's Hospital, and the title of her talk is Chicago Parents' Attitudes About COVID-19.
Thanks, John. I will share my screen. Okay. Can everybody see my slides?
Yes.
Okay, perfect. Thanks. All right. Hi, everybody. I am Marie Heffernan. My pronouns are she, her, and I'll be talking with you about Chicago parents' attitudes about COVID-19. And first, I wanted to just call out the team members whose names are on this first slide here, without whom this work would not be possible. Okay, there we go. So Voices of Child Health in Chicago is the program that I work for at Lurie Children's. We are a survey research program. And today I'll be talking with you about data from a newly launched survey project that we've started that has over 1,600 parents who we are surveying over time. So we're surveying the same panel of parents over time in a repeated fashion. And we call this the Parent Panel Survey. So through this project, we surveyed parents from all 77 community areas in the city. We recruited parents by mail with our survey partner, NORC, at the University of Chicago. And to be eligible for the survey, all parents had to have at least one child under the age of 18 who was living in the household, and they had to live within city limits of Chicago. Parents could complete the survey online or over the phone, depending on their preference, although the vast majority of parents completed the survey online. It was administered in both Spanish and English. And parents are not recruited from Lurie Children's, from patients or families who go to Lurie Children's, although our sample likely does include parents whose kids have care at Lurie Children's, incidentally. And so we're administering 3 surveys per year on various topics, and this allows us to explore trends over time in data. So for instance, trends in parents' attitudes about COVID, and to also add new topics to each survey wave so that we can explore issues and public health issues as they emerge. So for example, in our first wave of the survey, which is where the COVID-19 data that I'll be sharing with you today comes from, we also asked some questions of parents about other topics like bullying, cyberbullying, and social emotional learning, parenting support, and substance use. And the data from wave 1 was collected from May to July of 2020, and all analyses that I will present are population weighted. For the demographics of our sample, we had a total of 1,642 parents. 68% were women, 30% were men, and 2% were non-binary or other gender. For race and ethnicity, we had 39% Latinx, 22% non-Latinx Black, and 30% non-Latinx white. 9% were multiracial or other race. And among the households that we surveyed, that represented 2,846 Chicago children. So we know that parents, children, and families in Chicago have faced unprecedented challenges during the COVID-19 pandemic. Families have had to adapt to drastically different routines and new concerns about their family's health and well-being. So we asked parents questions, these 3 questions about COVID-19. So how concerned are you about coronavirus or COVID-19 affecting your family's health? How much confidence do you have in information about COVID-19 from the following sources? And how likely would you be to get yourself or your child vaccinated against COVID-19 if a vaccine were available? And we see that Chicago parents were quite concerned about COVID. So overall, 64% of parents said that they were very concerned about COVID-19 affecting their family. 31% said they were somewhat concerned, and only 5% of parents said that they were not concerned. There were some differences in concern by demographics, and I'll go over some of these differences that reached statistical significance at p is less than 0.05. And so first, to kind of give you the background of this heat map that you see on the screen. So on the very top level, you have the levels of concern from not concerned, somewhat concerned to very concerned. And then each row represents responses from parents of different race or ethnicities. And so we can see that non-Latinx Black parents were the most likely to report being very concerned about COVID-19, with 75% saying that they were very concerned, followed by Latinx parents. 69% said that they were very concerned, and then multiracial or other race parents, 63% said they were very concerned, and non-Latinx white parents, 49% said that they were very concerned. And we know that in the United States and in Chicago, the COVID-19 pandemic has disproportionately affected communities of color due to structural racism. So in Chicago, we know that the majority of cases of COVID-19 and the majority of deaths related to COVID-19 have occurred among Latinx and non-Latinx Black populations. So we see here that parents' concerns about COVID reflect this disproportionate impact of the pandemic. Concern about COVID-19 also differed by household income. So in this heat map, each row represents a different household income level. We see that parents who were middle income, so 100 to 399% of the federal poverty line, they were the most concerned about COVID-19 affecting their family's health, with 72% saying they were very concerned, followed by parents with a household income below the federal poverty line. And then those with the highest household income, 400% or above, only 53% said they were very concerned. And we know that parents with low to middle income may be less likely to be able to telework than parents with higher income. And it's also known that essential workers face higher risk of COVID-19 infections than others. We also asked parents to report on their own health. So if a parent said that their health was excellent or very good, we grouped them as having better health. And if a parent said that their health was good, fair, or poor, we grouped them as having worse health. And so in general, we see that parents are concerned about COVID-19 affecting their families, but they were even more concerned if they were in worse health themselves. And this greater concern among parents with worse health themselves aligns with research showing that people who have underlying health conditions have more severe outcomes from COVID-19. We also explored this with respect to the health status of children in the family. And we found that this did not differ. So parent concern did not differ significantly by the health status of their children. And it's interesting to consider why this might be the case. So it could be that one of the main headlines we have been seeing about COVID and children is that children don't get as sick as adults, but that is not necessarily true for youth who have chronic health conditions. Next, we examined which COVID-19 information sources parents had the most confidence in. So in this figure, you'll see the darker blue dots represent the proportion of parents who said they had lots of confidence in each information source. The teal dots represent the proportion of parents who said they had some confidence in each source. And the green dots represent the parents who said they had little to no confidence in each information source. And then each row represents a different information source. So here we can see that parents were most confident in information from doctors, with about 60% of parents saying that they had lots of confidence in information about COVID-19 coming from their own doctor or their child's doctor. About 50% of parents had lots of confidence in information from hospitals and public health websites. And 25% of parents had lots of confidence in information from the news. And only 16% of parents had lots of confidence in information from social media. Importantly, we saw that parents who had a child who was in worse health were less likely to have lots of confidence in COVID-19 info that came from their child's doctor than parents whose children were all in better health. And a similar pattern emerged for parents' own health and their trust in information from their own doctors as well. When we explored trust in information sources by parent education, we found that parents who had a college degree or higher were more likely to have lots of confidence in information from their child's doctor. 70% said they had lots of confidence in that information, compared with parents who had some technical school or some college, and parents who had a high school education or below. 53 and 55% said that they had lots of confidence in information from the child's doctor. The last COVID-19 topic that we asked about was COVID-19 vaccines. So when we asked parents about their likelihood of getting a COVID vaccine for their child, 49% said that they were very likely, 19% said they were somewhat likely, and 16% said they were not likely, and another 16% said they were not sure. And these percentages are almost identical to parents' plans to get a vaccination, a COVID-19 vaccination for themselves too. There were some differences in COVID vaccination plans by demographic and other factors. So for instance, parents were less likely to get a COVID vaccine for their child if their child was in worse health than if their child was in better health. And this is concerning that parents who have a child in worse health were less likely to consider getting a COVID vaccine for their child because children who have underlying conditions may be more at risk for some of the more severe outcomes from COVID-19. When we explored COVID-19 vaccination plans by parent race and ethnicity, we saw that non-Latinx, multi-race and other race parents and non-Latinx white parents were the most likely to say that they would get a COVID-19 vaccine for their children, followed by Latinx parents and non-Latinx Black parents. And so here we see that among communities of color, where we saw the highest level of concern about COVID-19 for their family's health, we're also seeing a lower likelihood of getting a COVID-19 vaccine for their children. And then when we explored COVID-19 vaccination plans in connection with past vaccination patterns, specifically the flu vaccine, we saw that parents whose child received the flu vaccine last year were more likely to get a COVID vaccine for their child if one becomes available than parents whose children did not receive a flu vaccine last year. Parents' likelihood of getting a COVID vaccine for their children was also associated with the parent's age. So 55% of parents who were 46 years of age and older said that they were very likely to get a COVID vaccine for their children, followed by parents who were 26 to 45 years of age. 48% of those folks said they were very likely to get a COVID vaccine for their kids. And younger parents, 18 to 25 years old, only 23% said that they were very likely to get a COVID vaccine for their children. And this maps on to some of our previous surveys on flu vaccination rates that show that younger parents were less likely to vaccinate their children against the flu than older parents. And finally, parents' likelihood of getting a COVID-19 vaccine for themselves was associated with their likelihood of getting a COVID-19 vaccine for their children. So this makes sense. So 94% of parents who were very likely to get a COVID vaccine for themselves were also very likely to get a COVID vaccine for their children. And then on the flip side of that, 92% of parents who said that they were not likely or not sure about getting a COVID vaccine for themselves also said that they were not likely or not sure about getting a COVID vaccine for their kids. So some of our key takeaways are that Chicago parents are quite concerned about the pandemic affecting their family's health, and this concern differed by demographics. And the differences in concern that we see by race and ethnicity speak to differential burden of illness and stress that communities of color are facing because of the pandemic. And I think it's important that we are sensitive to this differential experience of stress related to the pandemic. Parents also had the most trust in COVID-19 information that came from their doctors, both their child's doctor and their own doctor. And they had the least amount of trust in COVID information that came from social media. The majority of parents said that they were either very likely or somewhat likely to get a COVID vaccine for their children. This differed by demographics and family variables such as child health status, parent race and ethnicity, and past vaccination patterns. Knowing that families, for instance, who did not get a flu vaccine last year were less likely to plan to get a COVID vaccine if one becomes available could be helpful to help with public health messaging and understanding or better understanding families' concerns about potential COVID vaccines. In our second wave of data collection for the parent panel survey, we will be further exploring COVID-19 and how it impacts families. So wave 2 of the parent panel survey is in the field right now for data collection. And we'll be asking about some of the same topics. So concern about COVID, trust in information sources, and vaccine hesitancy so that we can explore changes or stability in parents' attitudes about these topics over time. And we'll also be asking some more nuanced questions about vaccine hesitancy, for instance, to get at some of parents' reasonings for either wanting to get a vaccine for their children or not wanting to get a vaccine for their children. We'll also be asking about childcare and remote learning setups, prevention strategies that families are taking, such as mask wearing, parents' experiences with telehealth, if they have had experience with telehealth and how satisfied they are with that. And then the pandemic's impact on their children's mental health and behavioral health in the family. So here I have our website, luriechildrens.org/voices, where you can get some more info about specifically COVID-19 and families and some of our other reports. And then I also have my email address up there. If you have any questions after our session today, please do feel free to email me. Thanks.
Thank you, Marie.
We have one more presenter in the session, Joshua Longcoy and from Rush, and the title of his paper is A Look into Racial Disparities of ED Visits, Hospitalizations, and ICU Admissions Among COVID-19 Cases at a Hospital System in Chicago.
Okay, I'm trying to share my screen. Let me share the right screen real quick. Okay. I believe I'm sharing the right screen.
Yep, looks
okay,
good.
So, okay, thank you for the confirmation. So yes, like you said, my name is Joshua Longcoy. I am working at Rush. This project was part of the beginnings of a bigger project in which we worked with the RUMC Health Equity Research Group, and then also we were working with the Chadwick Institute in Nepal, specifically with Dr. Scott Smith. But that's more of the bigger project. This one is giving an idea of the beginnings of the project. So yeah, like the title says, we're looking at racial disparities of ED visits versus hospitalizations in COVID confirmed cases in Chicago and the neighborhood area. So I'm sure everyone's heard this quite a few times today, but since 2000, beginning of 2000, there have been over 9 million cases in the U.S. and 235 deaths due to COVID-19. In the state of Illinois, there's been north of 456,000 and 10,000 deaths. And then also in the city of Chicago, we've seen over 110 cases and 3,000 deaths as well. And like others have said, the non-Hispanic Blacks and Hispanics in Chicago were the hardest hit. When you compare them with whites, the Blacks were 2.6, rates were higher, and 5.1 cases per thousand, compared to just the 1.8 in the white community. So a couple of papers kind of motivated this study, but a lot of studies have shown that racial and ethnic minorities and social economical disadvantaged groups are disproportionately being affected by COVID-19. Three studies that we found, this is back when we started, there's been several more since. They compared hospitalizations of Blacks to whites, and they found similar things. So one paper out of California, they found that 2.7 times more likely to be admitted than whites. A paper out of New York, I believe this one's New York, there's 93% higher being hospitalized than whites. And then Louisiana, this health system found that 2.4 times more likely to be admitted. They also, however, these studies, they came out right when, at the beginning of all this. So most of the studies that they did, this included March, April, and or May. And then there's a paper out of Boston that looked at the city of Chicago, and they took the medical examiner's data, so that's deaths, and then they compared it to community level data. And what they found was, indeed, community level effects also have, an effect on mortality and stuff like that. So like the census tract in the highest poverty quartile had the highest mortality rates in Chicago. And then also non-Hispanic Blacks and Hispanics had high mortality at all ages from COVID-19 in Chicago as well. So this one was, looking more at the health system at Rush, trying to answer similar questions. So among whites, Blacks, and Hispanics, is race and ethnicity associated with the likelihood of being hospitalized among COVID-19 confirmed patients presenting to the ED at Rush in the Chicago area. So the population for the study, we use electronic health record data collected through the Rush system from March all the way through the end of September. They had to be seen at the ED, and then they had to be, of course, COVID confirmed positive. And at the Rush, they also have quality checks to make sure that it wasn't false positive or anything similar to that nature. So the three major hospitals were the main campus, which is Rush University Medical Center, Rush Oak Park Hospital, and then Rush Copley Medical Center. Since we're looking more for like, what drives a person to actually be admitted, we did exclude people that were transferred from other hospitals, transferred from nursing home or skilled nursing facilities, because most likely if they were transferred from the hospital, there was more due to care, and they would probably just get admitted right away. We also excluded telehealth visits, no residential address, which was just a couple. And then since we were looking at mostly Blacks, whites, and Hispanics, we excluded the other races as well. Since a person could have more than one visit, we only took the first visit of a positive test, or the first visit after a known positive test. So essentially, they had to be the first visit they were treated at Rush for COVID. Okay, there you go. So the main outcome was, of course, hospitalizations. We were looking at whether a person was admitted to the hospital from the emergency room within the first 24 hours. This is just a quick map showing the wide range of location of the patients. It's zoomed out pretty far, but you can kind of tell the red were Copley patients, blue was Oak Park, black was RUMC. And you can see that it spans quite a bit. It's not just urban, it's also rural patients as well. And majority seen at each hospital was, in fact, Black and Hispanic. So kind of the predictors we use for our statistical analysis there. We use race and ethnicity, age, gender, and insurance type. We also included kind of a community predictor as well, so socioeconomic status. This was taken by when we geocoded each patient's address, then we assigned the percentage of income under poverty to that patient, and used that as well on the model. And then for the comorbidities, we took the ICD-10 codes assigned or diagnosed, whatever, after at discharge. And we grouped them according to the HRQ's standardized categories. And we used as guidance the CDC's list of comorbidities that were associated with more severe COVID-19. So for the statistical analysis, we use frequency tables and Nova describe the relationships between, the basic characteristics. A multiple variable logistic regression was used to examine between patients' characteristics and hospital admission. And then we also looked at it, since we're really interested in race here, so we also stratified the logistic regression according to race. So some basic demographics. Again, the data was collected from March to September. We had a total of about 4,000 patients. About 12% were white, 40% blacks, and 49% Hispanics. About half of them were males. Majority of them were actually self-pay or this other category, which at the bottom of this table you can see it includes the COVID versus uninsured. So self-pay and the uninsured category came up with the bulk of the self-pay and other category or group. The median age was 48. And then as far as racial differences, whites tended to be in the 65 and older age group, whereas blacks and Hispanics were of similar age. Blacks and Hispanics also tended to be more of self-pay and in the other category as well. So this is looking at the comorbidities, both in total and then also by race. We saw that 45% of the patients had some kind of history of heart disease. 62% of the patients had at least one comorbidity. About 15% had at least 5 comorbidities, with the highest being like 9 of them, which all 9 are listed here from the CDC website. And then the median was about 2. Blacks had a higher proportion of being obese, and Hispanics had fewer comorbidities. So in a way, if you look all the way down the list of the table, you can see that the frequencies, so these are actually row frequencies, and you can see the Hispanics kind of had the lower frequency in majority of the columns. The Blacks and whites also had similar counts of comorbidities, despite Blacks being younger. So that was obviously kind of interesting. About 50, so this is the unadjusted admission rates. So basically looking at the same demographic variables, but looking over at whether or not they were admitted or not. So about 58% of the patients were seen in the ED only, and about 42 were actually admitted. As one would expect, as age increases, the admission rate also increases as well. The admission rate was lower in females. The admission rate for whites was actually higher. And then those with Medicare had the highest admission rate. Because remember, the whites were more likely to be in the older category, and so that makes sense with Medicaid. Medicaid. Medicare, you're right. So self-pay and others were also mostly ED only. This is the same thing with the comorbidities, looking at the admission rate. The main thing to look at here is that basically if you had a comorbidity, you were higher, which one would expect you were higher likely to be admitted. So majority, however, the majority of the asthma people were ED only, but COPD, which is also a lung disease, had 80% more likely to be admitted. And diabetes with complications was 88%. So those were COPD and diabetes with complications. Those were high on the list of the CDC for translating into more severe case. Okay, so this is forest plot. So these are the list of the actual categories. These are the odds ratio with the associated 95% confidence interval. Blue dots actually indicate the odds ratio in the error bars as the 95% confidence interval. The first thing you see here shaded red is relative to white, the blacks are 50% likely to be admitted. Hispanics are equally likely to be admitted. The more comorbidities the patient has, the more likely they would be admitted. Is about 2 times likely. And then also patients with self-care are about 90% less likely to be admitted than those with private insurance. Self-pay, I mean, not self-care, which is maybe one would expect that. And then as far as the males, they were twice as likely to be admitted than females. And we saw no observed difference in the actual poverty levels or community level factor that we instituted as well. And then last but not least, the all age groups. So the reference in this was 0 to 35, and all age groups were more likely, basically as we saw in the frequency tables, that the higher age, the more likely you are to be admitted to the hospital. Okay, so one of the surprising things, of course, is the why would blacks less likely be admitted than whites? So we dived into it as, like I said before, the logistics stratified by race, and we found something. So blacks had more comorbidities than whites and Hispanics. Blacks were younger than whites, like we mentioned before. Whites were more likely to be 65%, 65 older age group than blacks and Hispanics. Blacks and Hispanics were about 2.7 times and 2.4 times more likely to be self-paid than whites. Blacks and Hispanics were more likely to come from high poverty census tracts. And then also females had a lower odds of admitted than whites. However, they actually had a higher odds of being admitted in the blacks and Hispanics community. So that if we go back to the table here, we see that males are 2 times more likely than females. Most likely that's coming from the, according to the last statement here, it's most likely coming from the Hispanics and the Black community. So this kind of like recapping real quick. So the older the patient was, the more likely he was to be admitted. About 62% of the patients had at least one comorbidity. The more comorbidities you had, of course, the higher the admittance rates. However, whites were older than Hispanics, Blacks, but Blacks tended to have more comorbidities, and Hispanics tended to have the least comorbidities. So Blacks and Hispanics tended to be more self-pay. So the surprising thing is Blacks are still less likely to be admitted. The admitted rates of whites and Hispanics were similar. So if the Hispanics were, according to the ICD-10 codes, if they were, maybe a little more healthy, it's interesting that the whites and the Hispanics, even though the whites had an older age group, their admitted rates was the same. So that leads us to what the big project kind of is. So again, the overall Blacks have the lower admittance rate, but what we're going to look for in the future is there any racial or ethnic differences in actually clinical metrics or severity, such as like oxygen saturation or other labs, such as like the PO2 score count. Also, we're going to look at how these relationships vary over time. So if you look at the Chicago Department of Public Health website, they had a graph that shows variation over time. Blacks were hit, at the beginning of it, and then Hispanics kind of, I guess, in the middle now or so, after the Blacks had come back down. And then if you look at it now, Blacks and whites are starting to even out as well. So what we want to do too is look at this particular subset, even though it's not a generalizable subset, it's just of this health system rush. We want to look at and see how the relationships vary over time. So we also want to look and see if the patient distance. So it could be that maybe Blacks are showing up to the ED maybe first because they don't have either access to testing, or maybe they're sick and they get nervous or something like that, or so they just maybe go straight to the ED or something. So we're going to look at the distance. Maybe they have to travel, and then also using the same concept again. We're also going to look at the outpatient testing as well. So maybe whites, are more likely to have the insurance. So maybe they were tested at the physician's office and then told to go to ED, which, they would only be told to go to ED if it was a worst case. So that was just a list of references, and then that basically wraps up my presentation. And I thank Paul for inviting me to give my presentation.
Excellent. Thank you very much. All right, we are going to open it up for a Q&A. So I'm going to monitor the chat, and if people want to post there, or if they want to unmute and ask a question directly to the presenters, it's fine too. Okay, this question is for Miguel. Is there a difference in number of folks who show up to mobile testing versus static testing sites?
If you can clarify, Elizabeth, if you can clarify that a little bit more, the number, so our static sites, because they do offer drive-through and walk-up, right now we have been doing over 1,000 tests and really over 1,200 tests per static site. When it comes to our mobile units, depending whether they're walk-up or drive-through or both, we have been having at least 700, 900 folks coming in to get tested at our mobile units. As far as the difference of there can be difference in demographics, if you will, and potentially more Latino and Black community members coming out to get tested. Again, we are deploying them to communities where there is a very high positivity rate. And these communities happen to be our Latino and our Black communities. Right now, the southwest side and the northwest side of the city of Chicago are communities and neighborhoods that have extremely high positivity rates. So while we deploy them throughout the city, we focus on some of these neighborhoods. And again, that kind of changes every week.
Great, thank you. I will give it a little bit more time for questions. If you have a question, please post it in the chat. I know it's been quite a long day, and we have a keynote session coming up at 3:50. Okay. Otherwise, I would like to thank our three presenters. The presentations were outstanding, and let everyone know that since we're recording, we will be posting the presentations on our website. And once that's all set, we'll let everyone know. We're also going to be sending out evaluations to all participants and people who attended sessions about the conference. So please look for that and fill those out. Those are incredibly helpful in helping us with the evaluating the conference and getting it ready for next year. Our keynote presentation, which starts at 3:50, is Kim Wasserman, Executive Director of the Little Village Environmental Justice Organization. All of you should have received a link, a Zoom link to her session that starts in a little over a half hour from now. So you have a bit of a break, but again, if there are any questions for our presenters, now is the opportunity. Otherwise, again, thank you for the presentations.
And I guess if I'll wait to see if there are any questions, but I will say, right, that in building these relationships, the importance of really ensuring that our Black and our Brown folks are working together to get through. There was recently a conversation with Silvia Puente, the president of the Latino Policy Forum, along with folks from the Chicago Urban League. And again, they really were advocating and cementing the notion and the idea and the need for the collaborations between our Black and our Brown communities. Over the summer, there were a lot of protests and conversations that really kind of needed to be had. And I think seeing the unity between the Black and the Brown communities really just makes the message a lot stronger, right? Because we do realize, just as in with voting, that there is power with numbers. There is also power with presence and that united front. And in addressing this pandemic, at least in my perspective, that's really the way it should continue being, to bring about various resources to our community members. I'm seeing the message from Mariana Martinez, core, whether we work outside of county. Right now, within the state of Illinois, where we are operating only in the city of Chicago. However, we're not limited to only operating in the city of Chicago. if there is the potential and the availability of funding from any of the municipalities within the Cook County area or within the rest of the state, CORE would be more than happy and more than willing to be able to step up and provide testing, look into being the manpower and the resource to administer testing to various municipalities and communities outside of Chicago and outside of Cook County.
Okay. Thank you all very much. I'm going to, we'll transition to getting ready for the keynote. Wish everyone a good afternoon, and thank you very much for your presentations.
Stay safe and stay healthy, folks.
Thank you.